So welcome, everyone, to the third installment of our discussion series on advancing health and social justice. So my name is Stephen Swartzer, and I am the Associate Director for Academic Programs at Fordham University's Center for Ethics Education. The Center for Ethics Education, which is directed by Dr. Celia Fisher, was established in 1999 as an interdisciplinary cross-campus unit at Fordham. The center embodies Fordham's commitment to intellectual excellence, social justice, and human dignity through the promotion of ethics education research and public dialogue. Our programs include an interdisciplinary master's degree program in ethics and society, an advanced graduate certificate program in healthcare ethics, the HIV and Drug Abuse Prevention Research Ethics Training Institute that has provided a significant amount of support for this entire talk series, and an undergraduate bioethics minor. In addition to these programs, we're also excited to have public-facing ethics and social justice programming that engages people in conversation about issues of contemporary social import. And that brings us to today's conversation about ethical implications of stigma and mistrust in healthcare and research. Before I introduce our panelists, I want to say a little bit about the procedure for this session. For those of you who have attended one of our previous sessions, we're going to be changing things up a little bit tonight. So we're going to be starting off with a roundtable discussion between our three participants, and that'll take us about 30 minutes. And then we'll be having a brief small group discussion using breakout rooms before then returning to the main room for a Q&A and continuing discussion. So if at any point during the discussion you have a question, you're welcome to submit it to either me or to Laura via the chat function, or you're welcome to hold on to it until the Q&A. Now, without further ado, I would like to introduce you to Alana Gunn, who is an assistant professor of criminology, law, and justice at the University of Illinois at Chicago, Nicole Overstreet, who is an associate professor in the psychology department at Clark University, and Laura Specker Sullivan, who is an assistant professor of philosophy at Fordham University. So we're now going to kick off the roundtable discussion by asking each of our participants to start saying a little bit more about themselves and what they work on, and then they will go ahead and take it from there.
Yeah, so I'm going to start by prompting Alana or Nicole, whoever wants to get us started. The first question that we wanted to think about is how did you get started working on stigma and mistrust? And so just share a little bit about your start with this work and the kind of work that you're doing now. Whoever, either of you.
Sure, I can start. So my background is in social work and in public policy. And so I would say I absolutely got started in this kind of work of understanding and working with populations and communities who are experiencing stigma and mistrust as a social work graduate student. And I worked with diverse communities of youth who were navigating stigma as they were trying to engage in mental health services within their community. And I'm just so being an intern there, I definitely was exposed to the ways in which youth of color, particularly in the city I'm in, which is Chicago, but definitely not exclusive to this city, are seeing not just experiencing stigma and mistrust when they're trying to engage in mental health services and building trust with practitioners, but also in their larger communities, their larger neighborhoods, the ways in which they see divestment, the ways in which they see the under-resourced aspects of their communities that's layered with surveillance and policing. So all this to say there are myriad ways in which youth were seeing having interlocking experiences with stigma and mistrust. And then as I got to the doctoral level, I did a lot of work within drug treatment, substance use treatment with women who had interfaced with criminal justice systems. So they were formerly incarcerated, engaged in residential treatment, and then absolutely again, and this was the heart of my dissertation actually, as a group facilitator, then as a researcher, I absolutely saw the ways in which women were not just experiencing and managing stigma amongst their communities in these treatment facilities, but also the ways in which the policies and the programming and the rules really cultivated, this perceptions of stigma and mistrust, the ways in which the women the ways in which norms were created, norms around the way the women should dress, the kinds of ways they were expected to engage in their relationships while they were in recovery. So for me, it's talking about cultures that reinforce stigma that then shape experiences of mistrust when trying to seek health services and really heal within communities.
Thank you so much. Nicole.
Yeah, so good evening, everyone. So my work sits at the intersection of social and health psychology, and I focus on experiences of violence, both ideological and systemic violence, with a particular focus on Black women's lived experiences. And so that's where I will start, and that's also where I will end, and just share that my lived experiences actually inform my knowledge of Black people's perceptions of oppression and bias in the healthcare. And my experiences in the academy actually contradict those truths of those lived experiences. So where I am currently is returning to the truth of those lived experiences and centering those in my work. And so to that end, I want to acknowledge that stigma and mistrust are byproducts of practices of systemic and structural oppression. So racism, sexism, interlocking systems of oppression, such as gendered racism. And those things affect how we treat and relate to each other. So experiences like prejudice and discrimination, but also how we treat and relate to ourselves. So these could be things like shame and blame. And as Alana was talking about thinking through this, what are some transformative pathways to healing where we think about relationality within our own communities? And centering that as a pathway to liberation and social justice and equity.
Awesome. Thank you so much for sharing that. And I'll just share. So I am somewhat newer to thinking about these issues. I'm a philosopher, so coming from, again, we're all coming from different disciplinary perspectives. I started thinking about mistrust in part because I was working as a clinical ethicist at the Medical University of South Carolina, which some of you might be familiar with. It is famous or perhaps infamous as the opening story or the opening fact of Dorothy Roberts killing the Black body is the case of Ferguson versus the city of Charleston, in which the Medical University of South Carolina had an informal policy where it was working with the Charleston County Sheriff's Office to report pregnant women who were found to be using illegal substances. They were then reported. Pregnant women were shackled by the Sheriff's Office after this reporting. And so that's just, again, one of the, I think, really powerful facts that I became aware of when I worked there. Medical University of South Carolina is also where John Marion Sims got his medical degree. Again, someone who is well known for previously being heralded as the father of gynecology, when really he developed that discipline by experimenting on enslaved women in South Carolina and in other southern states. So I'm interested, again, in that history, but as a philosopher, in thinking more carefully about mistrust in the context of justice, and focusing perhaps less on mistrust and more on this question, as I think we'll talk about as a group, about what our health institutions can do to be more trustworthy. So on that note, I think the next question that we wanted to think about are about the ethical issues surrounding stigma and mistrust. So we can keep the order we have. Alana, if you want to go first, and we'll go from there.
Sure. Let me see, how would I start? Well, in terms of the ethical issues with stigma and mistrust, I believe if we come to our health practice work, so whether that's as a health practitioner or whether it's even as a researcher who engages in health research, if we come to our work with an understanding that most of the communities that we're seeking to engage in this practice have been harmed by multiple systems of trauma and stigma, then it becomes an ethical issue at the start as to the way in which we then choose to engage with our clients. When we start from an understanding that everyone is coming to their practice experience, coming to engaging in services and research, having been exposed to, embedded in many systems of trauma and many systems of harm. And it also becomes an ethical dilemma around the idea of desiring them to trust us when we're asking them to engage in systems that have shown that they cannot be trusted. So that is absolutely, for me, it feels like an ethical dilemma to ask one to trust within this historical legacy, which even Laura, you know, illuminated just now, this historical legacy of mistrust. And I'd also say it also becomes an ethical dilemma when we are not, as practitioners and researchers, doing the work to understand the ways in which we are reinforcing stigma, the ways that we are reinforcing mistrust. So that's the way I see there are multiple ethical dilemmas. Absolutely.
Yeah, I echo everything that Alana said. And as I said before, I do a lot of research in violence, and I would say that it's quite a heavy bit of gaslighting to expect people to have trust in institutions that have historically shown that they are not trustworthy, and it's abusive. Right, it's harmful. So in thinking about that as well, I just would add that when we think about ethical issues and ethical principles like autonomy or beneficence or non-maleficence or justice, there's a paternalistic way in which we think about these things as these are things we give to BIPOC communities, and they're not, right? And I just want to be clear about that we know what we need and we know what we want. And it's being obstructed, right, intentionally. And so I think that we need to shift our focus to really think about that in all ways, not just, yes, structurally, of course, systemically, but also, as Alana pointed out, are we complicit in that? How do we uphold that? And how do we maintain that? And I think that the time is of the essence, is absolutely urgent to think about these questions because there's just too much at stake.
Thanks, Nicole. Yeah, I mean, echoing what you just said, there was an article in the New York Times a few weeks ago that was talking about I forget who it was, but it was someone part of a religious community who was going to African-American communities. I think it was in Philadelphia to talk about COVID vaccine uptake, right? Which is obviously like one of the huge issues with mistrust in a very like broad sense right now. And there was just a quote that struck with me, which was that the problem, I think he said something like, the problem is not misinformation. So when you said, you know, our communities know what they need, I think there is often this paternalistic assumption that, okay, well, maybe they don't understand, maybe they don't have the right information. And I think that that's a mistake that a lot of healthcare institutions make. Yeah, and I'll just add, you know, from my perspective, so as a clinical ethicist, the way that mistrust presented for me in healthcare institutions was being faced with patients and families who were, I think, rightfully mistrustful of healthcare institutions. And then as a clinical ethicist, my job was to try to figure out how to resolve that and still get them care. But it felt like a Band-Aid, right, on a much bigger problem. And so I think both of you emphasize that this is systemic, it's structural, it's about policies, it's about practices. And I think that's something that healthcare ethics is still learning how to talk about. Yeah.
Yeah, and I want to just shift a little bit closer to thinking about practices, right? So I've had experiences sitting on IRBs, and you said something about, focusing in on misinformation and do people understand? And that's if that's the angle, right? When you sit on an IRB, the emphasis is on how do we structure the consent form? Do we make, and all of this nonsense is like, not to me, it's nonsense to me. And I'm just gonna say that outright. It doesn't get us to thinking about, well, what is the issue that we're dealing with, right? Are we talking about, do people understand the consent form? There's a place for that. But if the emphasis is just on this, what are we actually talking about with regard to the practices and also the perceptions and also the accountability, right, that comes with knowing this history? So to me, those are the questions that we need to center. And I think if we do that, it definitely shifts the practices and the ways that we approach ethics, even within our own institutions. So I'll just add that piece there from my experiences on IRBs.
Mm-hmm. Yeah, my dissertation research was done in Japan, but it was interesting. It just makes me think that one of the things that came up there is that consent forms are not as popular in Japan, in part because there's this idea that if you have a consent form, it's not protecting the participant, it's protecting the institution. And if you're using a form to try to establish the boundaries of a relationship, in some ways you're already saying, like, we're not going to relate as people, we're going to try to basically like cover our asses and that's going to be the focus. Yeah.
And it's critical, right? Because it's like, that's a fundamental difference about a goal, right? The goal for me is like, you can all ask what the goal is for you, but for me is really thinking that Black lives are at stake. And so when I think about that, like, the university putting forth an informed consent to cover their butts, that's a fundamentally different goal, and that's going to have different outcomes. So this is what I really mean about kind of interrogating, where are we complicit and how do we uphold these things, even in the day-to-day, where I think it gets lost, especially in these moments of crisis, right? We're attentive to survival, and really, like, we really need to shift. It needs to be a fundamental shift.
Mm-hmm. Yeah. And this relates, our next question, this kind of just like leads into it. What we wanted to think about is about institutions being more trustworthy. And as you said, like, what does that mean in terms of actual concrete practices, where in something like focusing so much attention on consent forms, which a lot of philosophically trained ethicists really love to do, right? Seems to be something that is still keeping the power of that relationship squarely with the institution. And what does it mean to actually practice trustworthiness with different communities and in different contexts? So I wonder if you two could talk a little bit about, trustworthy institutions and trustworthy practices and what that might look like.
Absolutely, I can start. I was recently reading an article that talked about the ways in which organizational cultures can reinforce supremacist kinds of ideologies, the ways in which capitalism becomes reinforced within organizations, which then can be seen in interactions between practitioners, colleagues, and how we engage with our clients and even those who are engaging in research with us. And it talked, and I love the way that you all brought up paternalism, because it talked a lot about these notions of perfectionism, how one's recovery should look, how one should demonstrate productivity within organizations, a lack of sharing power, a lack of collectively honoring that we all have knowledge, we all have expertise, our clients have expertise, our research participants have expertise. Thinking about continuing to think about the ways in which communities experience surveillance and trauma, and then how that seeps into how that plays a part in how individuals then engage in their healing practice, and how individuals engage in research. So I really think that in order for us, in part, to really disrupt oppressive systems or oppressive practices within systems, we have to think about the ways practices of perfectionism, paternalism becomes embedded in our practices, and really reinforces this ableist notion of how people should recover. And I could even think about, in my research, how I've interviewed countless women who've been impacted by interlocking systems, so criminal justice system, child welfare systems as moms, as parents, mental health services, substance use systems, and then then they come to my work, they come to my practice work and my research work, and here I am asking them questions to think about these experiences of trauma, and I quickly found myself in partnership with them, realizing and seeing the ways in which language matters, the way in which the kind of language that we use to talk about their experiences with sex work, their experiences with trauma, their experiences with surveillance. I've had participants say to me that the site I chose to interview them in mattered. It mattered that I gave them priority, and I honored and listened to their sense of comfort and security. It mattered that I interviewed them in my office, because that showed a level of respect. That showed and that demonstrated a sense of honoring their experiences and putting a level of significance on their values. So I do think that when we're engaging with participants in research or as clients in healthcare systems, understanding that in order to create trust, build trust, create trust within cultures that they aren't existing for reasons that we've mentioned, we have to remember that people are bringing myriad traumas to these experiences, and our practices matter. Our practices matter for that, for building trust.
Yeah, I wonder if you could say maybe a little more about that. One of the questions I've often wondered about is the distinction between like performative trustworthiness and real trustworthiness. So I can imagine like a similar researcher, doing some of the same practices that you've described, right? Like bringing someone to their office and like choosing a location, like using the right words. But could you say a little, like, because there's clearly like a very robust sense of trustworthiness that I think is underlying what you're describing. And it's, so I wonder if you could just say a little bit more about that.
Yeah, wow, performative trust. I will say I've been in a few interview spaces and even academic spaces where I showed emotion. I showed varying levels of emotion, and I'd say that initially I was taken aback by that, and I was bothered by that, and I wanted to reflect upon how I can stop doing that, how I could eliminate that from my engagement, whether it's at work, in academic spaces, or in my research. And I really came to terms with that, and really understanding that when you bring your emotion, when you bring care to your work with individuals who have experienced different forms of marginalization, that also creates trust. That also creates trust, because how do we engage in having them tell their stories, ask them to tell their lived experience and stories of decades sometimes of trauma, cycles of trauma, and not show some care and show some emotion. So I personally have become pretty comfortable with the ways in which emotion and care should be embedded in processes of healing and processes of research and processes of building healing justice. And I not only say that in terms of what I feel, but my response back from my participants have been very thankful of the kind of spaces that I created that helped to build trust, in large part because I was showing care to them in the way I spoke to them. Even, I'm not saying that everyone should cry in research, that's absolutely not what I'm saying, but I think we've divorced emotion and care from our work. And I think that's problematic because our work is lodged in understanding experiences of trauma and oppression. And I think showing care, demonstrating care can go an incredibly enduring long way in building trust. Yeah.
Absolutely, 100%. And it's not transactional, right? It's not like, oh, you give me this and then I'll give you this. That's not how it works. And honestly, I was just going to ask everybody to just take a moment and think about people that you trust. Like, these are people that you're in community with. These are people that you have relation with. And these are people that have shown that care over time. That time over time, right? And I emphasize that because the neoliberal structure of our institutions, the capitalist structure of the ecosystem generally is not built on care. It's not built on taking the time. And I really think that that's something we should be thinking about when we say transform. That's something we need to transform. That's a culture we need to transform. Those are practices that we need to transform because they're integral to doing this work, right? This slow work, this caring work is absolutely vital. And the other thing that I would say is becoming whole on these are centuries of oppression, centuries of exploitation, unpaid labor, ongoing. How do we account for that? Right? I see us getting a lot of grants, millions of dollars. I see getting a lot, I don't have the $1 million grants, but I'm just saying, like, how can we think differently about that money? And that's a real question. Yeah. Go ahead, Alana. Go ahead.
I'm sorry. It just, hearing about grants, hearing about building trust, it made me think about the Robert Wood Johnson Foundation, which to me really feels like it has awesome goals and aims and tenets really embedded in critical participatory action forms of research, where researchers are working with community partners in equitable, shared kind of governance ways. We're working together. We are developing our questions together. A large part of the time that we spend is embedded within the communities, building the trust. So kind of to go along with what Nicole said, we can't just show up to an interview room and think trust will be established right away. It absolutely takes time. It actually takes the building of a relationship over time. It absolutely also takes a shared partnership where those in a community can see researchers working in equitable ways with those agents of change who are within the community. And I really think that Robert Wood Johnson has an awesome understanding of the ways in which we address health disparities through community engaged, invested, shared partnership between researchers and community members.
And I just would say a little bit more that I just wanted to call in some of the work of Michelle Fine, Patricia Hill Collins, Vanessa Gamble, and thinking thinking about community participatory research action methods, youth participatory action research methods, really a full collaboration process from beginning to the end, where BIPOC communities are at the helm. We take the back seat, honestly, and think about how do we make those conditions possible to have a trustworthy process, and then also scaling that up to think about our institutions as well.
You know, just to piggyback on that, it's funny, Nicole, everything you're saying, it's making me think about real-time examples that I'm living and working through now. And so
it's very real right now.
Yeah. And so, you know, as I kind of already started to talk about, I'm engaged in a research project now, a Robert Wood Johnson Foundation funded project, where I'm working with a community partner, and I'm also working with a public health scholar at UIC, and we're looking at how hypersurveillance affects health outcomes for communities that are also navigating former criminal justice involvement. And I'll say, just as a really poignant example, our beginning sense of how we would approach this was that we would absolutely amplify the voices of community members who are part of the Chicago neighborhood who are experiencing incarceration. We would use photo voice. We wanted to use ethnographic in interviews to really understand the way in which they are experiencing hypersurveillance and structural violence. Our community partner said, you know, I'm tired of research that's being done just on those who are harmed. Why aren't we not also looking at and speaking to those policing systems? They need to be a part of this research process. This was not talked about initially in our proposal to RWJ, but once our community partner came to the table and really talked to us, you know, and really reflected upon the ways in which she really felt as if policing, the voices of police officers and community correction officers needed to also be a part of understanding and unpacking hypersurveillance and its impact on health. We quickly made that a part of our research questions. And that's what we're going to do along our process of research, you know? And so I really believe had the public health scholar said, no, but we're focused on amplifying the voices of the community. That's the research that we believe is critical. We would have harmed trust before we even got into this process of building, sustaining trust and partnership. So I think from the outset, just as Nicole is talking about with CPAR, from the outset, there has to be an understanding of creating shared partnership between researchers and community members. From the outset.
100%. And I would echo to what you said earlier, Alana, about like what logics are we divesting from, right? Like if I was a researcher who said, oh, I'm really invested in the project that I proposed and that's not what I proposed, right? We're now having some sort of allegiance to something else that isn't the work. And so I just wanted to echo that and also add to that the research tells us when BIPOC communities participate and are absolutely willing to participate in research. And I want to echo that. So it is when privacy is maintained and confidentiality is maintained. And I want to say, if you're doing research on HIV, substance use, et cetera, the reason why that's critical, right? Like it should be obvious, which is that these are precarious times, even more so now, right? Thinking about like, what is the impact of a breach and confidentiality and privacy? Is there trust in the research team? We just talked about that and covered at length about what it takes to create that trust, but you can also think about who you trust in your own life and have you met that standard in the research, right? And then I think also mentioning here too, financial compensation. And also if they see the research as an opportunity to help themselves or a loved one. Are we reaching those bars? Are we reaching that standard? And if the answer is no, then we haven't built the conditions for trust, right? And that mistrust, that suspicion is warranted, right?
I love that example that you just gave of changing your research questions and changing research in response to what your participants are saying that they're interested in, because I think that's a really concrete example for a lot of researchers of how these structures of power kind of implicitly affect research priorities, right? Like we all know, like, you submit research protocols based on what funding agencies want to see. And there is this idea that, okay, you're responsive to their needs, but why aren't you responsive to your participants in the community? And I love that. I think that that's really tangible. And it one of the things it makes me think too is, Alana, what you were saying about showing emotion with your participants. Part of it is, right, a big part of trust is vulnerability, because when we trust people, it's because we're trusting them to account for our vulnerability with care, like you said. And I think part of what you were showing is that that does go both ways, and trustworthiness shows like you're willing to make yourself vulnerable to your participants, both emotionally, but also in terms of changing your research. And so it's that reciprocity that,
For sharing. Yeah, absolutely. Yeah.
Awesome. We're just at this is exactly when we wanted to switch to breakout rooms. So I don't know, Alana or Nicole, if you have anything you want to say before we send people off, but otherwise I think we'll let people chat about this. Okay. All right. So I think now the plan, I think Stephen's going to be working in the background to set up some breakout rooms. Awesome. So the questions that we're hoping people will think about, and this is just for about 15 minutes. So our plan is to come back at 6:25. I think we're going to be putting you into breakout rooms of about, I think our goal was 6 to 8 people. Awesome. So the questions that we want you to think about are, a lot of the things we were just talking about. So to whom are researchers and healthcare providers currently accountable to? To whom do we fail at being accountable to? How do these failures and accountability influence stigma and trust among marginalized groups? What structural changes can we make to transform these issues? And what transformations are needed in how we engage ethics in our work? And I know that was a lot, so I'm going to copy and paste these questions into the chat, and I think you should be able to still see them when you go into your breakout room. So I'm just going to paste those now. And so, yeah, our hope is that maybe start off, everyone introduce each other. I think these are going to be random, so you'll be making some new friends and talking about mistrust, stigma, accountability in healthcare and in research. And yeah, Stephen, I guess whenever you're ready.
Okay, so the room should be set and we will be opening them up now.
All right, see you all back here in 10 or 15 minutes. You can send your question directly to me or Stephen, and in that way we could do it anonymously. If anyone wants to ask an anonymous question, you can post it in the chat, or again, you can raise your blue hand. And if you want to just join us in chat, that's welcome as well. We'll maybe give a few minutes for people to get themselves collected. We'd even just love to hear what different rooms talked about, if people want to get us started that way.
Well, I'll invite John Hatcher, who was appointed for my chat room, to begin with what we were discussing. That's okay, John? Yeah.
And I know that we were cut off at the end, so I forgot who was speaking, but they can jump in too.
Natasha.
But we were talking about that building a relationship takes time, and it's over maybe a long period of time, and how going to the community and asking what they need and really conducting a needs assessment is like almost one of the first things that should take place, because otherwise you're not really taking in the needs of the people that you're trying to serve, trying to help. Where did we go after that? And
I had just kind of mentioned where I felt like the needs assessment, so it kind of removes that power barrier there, like where I feel like if you're asking somebody what they need from you rather than them having to come to you and ask you for help, I feel like it kind of removes a little bit of the power struggle or power difference.
Yeah, and so maybe putting it in that language of accountability that we ask these questions in, it's like as a researcher, showing that you're going to be accountable to the community because you're asking them what their needs are. And then ideally the next step is like doing something to try to meet those or to figure out how you can help rather than, again, like being accountable in a more top-down way to an institution or a funding agency.
We were also talking about making healthcare relational. And so not just a researcher asking a community what they need, but when you sit down with a physician, they say, why are you here? What do you want to get from this meeting with me and your healthcare? And to kind of shift somewhat the power, but also to underscore the relational component that I think Nicole and Alana were talking about. And then I think John was talking about how e-health can also provide physicians with the ability to check in. That may also encourage more of a relational form of healthcare.
Mm-hmm. Yeah, Nicole and Alana, feel free to jump in anytime. I do see Victoria Munoz's hand is up. But yeah, Nicole, feel free to unmute yourselves and just hop in at any point.
I was just going to say quickly that, thinking about what Celia just said is just like the structure of healthcare isn't really designed to have that kind of relationship. And so we definitely need to transform kind of like, it's really every element, right? Like of how we're thinking about this. And that to me sticks out, especially in this moment.
That was actually kind of what I was going to touch on. I feel like it's very easy to say we should have X goals, but I just think this whole like for-profit healthcare system doesn't really allow for that. So it's kind of like burdensome on the health providers. Like I know my mom's a doctor and she says it's a struggle because she wants to connect with patients. She wants to check in via e-medicine whenever she can, but there's just simply not the time. And she was like, and if I don't see X amount of patients a day, then I don't make any money. If I don't make any money, then no one wins. So it's just kind of like, I think we would take it further back. The problem isn't necessarily physicians not putting in the proper attention or time. It's the fact that there is no time. And why is there no time? Because it's for profit. So I feel like a lot of these conversations can be brought back around to the negative consequences of having a capitalist type healthcare structure.
Mm-hmm. Yeah, that's exactly what my room was talking about, is that, when we ask who are we accountable to? I mean, a lot of people are just accountable to who has the money. And that's a problem that can feel really insurmountable for individuals. And so I think like, right, on the one hand, there's this like big systemic problem. And then the other hand, there's like the agency of individuals to do something within that. And sometimes recognizing that big systemic issue can feel like it's really taking away any agency to do anything. Yeah. We have a question from the audience. If, again, I'm just going to read it out loud. And this is actually echoing what Victoria just said. But it says, I just wanted to say that I really appreciate Alana's framing of the decision to try to build trust among people who have learned to cope with unjust systems through distrust as an ethical dilemma. One question I have is whether we need an entire reimagining of our profit-based healthcare system to where healthcare is no longer treated as a market good in order for clinicians to prove themselves to be trustworthy. Yeah, I would say yes. Yeah, and I think just feel free to jump in, Alana or Nicole, but I think this is where the trustworthiness part I think becomes really hard, is that I think individual healthcare providers might do their best to try to be trustworthy, but when you're within an institution that is prioritizing the bottom line, you're going to get pushed from above sometimes as well. And so it's hard to figure out just how much control you always have over whether or not you're incorporating someone into a trustworthy institution. Alana, I see you're unmuted if you want to. Was that intentional?
It was intentional, but I'm still reflecting. Yeah, no, I'm still reflecting, cool. And yeah, but I'll have to say.
Let me ask a question to Nicole and Alana. How should the reality of racism be recognized especially in healthcare settings? You're sitting there with a doctor and all they're interested in, or in a mental health care professional, and they're looking to see if they can diagnose you with a DSM, or they're looking to see, if you're diabetic, without asking or validating the stressors that are involved, both interpersonally and social, politically right now, that are also having this impact on one's health.
So in part, I'm really thinking about what would it look like as healthcare practitioners to centralize, to really centralize and prioritize, and understanding and trying to gain knowledge about the ways in which the communities that we're servicing have experienced trauma. So whether that's racialized trauma, that's whether that comes in the form of policing, or whether that comes in the form of their previous experiences where they experienced racism as they were trying to access needed services. So what would it look like? How can we imagine a practice of engagement where we're taking those experiences, we are allowing individuals, clients to come in and bring those experiences to bear on our practice and help us to understand what they're bringing into this practitioner clinician experience? Like, what does it look like, and what are the challenges that would come to doing that work within a larger capitalist system that really prizes productivity, that really puts power on the way in which we see recovery and growth and certain kind of measurable goals, but how do we disrupt this kind of this also ableist, and capitalist way of trying to engage in care by allowing our clients, our research participants to come and bring in their lived experiences of racialized trauma that absolutely is going to affect our work. Like, how do we bring that into these spaces? Because we need to, I guess is what I'm really saying, like, because it needs to happen. It needs to happen.
And I'll add to that and just say, like, it's really clear to me that the reform route is not the route here, right? Like, and I just want to say that clearly, because we see with the movement for Black Lives, the call is to abolish, the call is to defund, and it makes sense, right? Like, if we're asking for a vision of the future, an imagination of what that looks like, we already have that in the visionary policy of that movement. And so it's very much about self-government, self-governance, collective self-governance is very much about collective self-determination. And it's not about what we can give, it's really about setting the conditions of possibility that are already known. And so I just want to echo that and amplify it here in this space, that the pathway is there. It's just being obstructed, and us thinking about our complicity in that is very critical. So I'll just add that there.
Awesome. And we have another audience question. So I have a feeling, I have a sense of what you two might say based on what you just said, but the question is racial bias training and education enough to combat internal bias within healthcare? And there's a follow-up saying, or would you Like, would taking a look at statistics on diagnoses yearly and examining how they relate to race be less prone to human error? So I think broadly the question is about how individual bias plays into racism within institutions.
Yeah, so I definitely feel like my last answer is the answer, right? So again, every solution that we talk about with regard to anti-bias training, anti-racism, these things are perspectives that are not shifting us out of an old model. It's about keeping us within the same model, and we really need to think about shifting out of it. And so that is the task at hand. It is a difficult one. It's a vulnerable one. It's one that requires us to come 100% with a full understanding of power and how we're complicit in it and how we divest from it. And that's the task.
Yeah, Victoria, I see your hand up.
All right, yeah, I have a quick follow-up question to that. I guess like obviously racial training hasn't worked. We're kind of sticking with the same pattern, but what would another solution look like? I know, like, I feel like I would think maybe a statistical like solution would be the best to kind of see like to make sure everyone's being diagnosed proportionately, like with the population breakdown. Do you think purely like a numerical solution also has its faults, or do you think it would be better to do a 180 and try that instead?
I don't want to take up too much space here, but one of the things that I think really in my own transformation that has stuck out is really taking some time to just think about, not even think about, but feel what it is that you're doing, right? The questions that you're asking, and also feel like the structures that we're in aren't allowing for this deep kind of critical work that's being called for to do the things that Alana gave light to, which is building trust, which is having care. And really thinking about that. It's a feeling process that we have been trained out of doing, right? And we need to become very comfortable with that in ways that we are not now. We need to bring the human into a science that has been stripped of that. So to me, I think that that's what's been guiding a lot of this work and leading the transformation and I'll say that for myself.
I'm finding myself thinking a bit about not racial appreciation, I don't kind of training, but compassion training on compassion and cultural humility. And the reason why I'm saying that is because I did a training the past 2 weekends where health practitioners spend hours with each other in virtual spaces like this, unpacking all these myriad interlocking oppressions and how our lives had been impacted by them. So how have our lives been impacted by racism, by sexism, by gendered oppressions, by sexuality kinds of oppressions, by ableism, by capitalism. And during this process, and we all were situated at different axes of powers, different professions. We came with different kinds of intersecting identities. And we spent hours of time over the weekend really building community and building a sense of compassion for each other's oftentimes kind of divergent experiences, because we spent time thinking about how myriad forms of oppression shape us in terms of creating and reinforcing devaluation, and also afforded us myriad kinds of privileges. So understanding this intersection of oppression and privilege, and I absolutely believe that because of that time we spent together as a community, understanding the ways in which we were harmed and benefited from these systems of oppression, that absolutely will shape the kind of work that we do. We even looked at the ways in which our organizations our structures that we work in are still really reinforcing these ideas of what productivity looks like, even amidst this global health pandemic where people are coming to work or showing up virtually to work or coming to work sick, having myriad forms of trauma due to anxiety and fear and lack of resources. And what does it look like to try to work in a productive way during this time, and how a lack of understanding of how trauma is collectively permeating our lives is reinforcing ableist practice, is reinforcing capitalist practice, is reinforcing racist practices, and so us spending that time just to sit with our different kinds of oppressions and our identities and thinking about how it shaped our work was incredibly useful, was incredibly transformative, and so I'm imagining spaces where everyone got to do that. That's what I'm saying. And
I'm gonna be real. I'm not trying to do that work with everybody. I gotta be real right now. That work again is care work. That work is work that I'm gonna do in a community of trust. Like I'm gonna do that work in a community of trust. But also just thinking like, yeah, like these are some serious times, and that the impact of that. How are we continuing on? How are we being complicit in it? And where do we pull back and just say, no, I'm not going to do that? And then also thinking about who can't do that.
Yeah, I was thinking as Alana, as you were talking, and Nicole too. The initial question, right, was in part about bias and whether or not removing human error was the way out of it. And what I hear you saying is like the problem is human, but like the solution is also human, right? Like the temptation is to, try to push things off to technology and statistics and to say like, let's take the human out of it. But I think this call to like compassion and to relating to other people is saying like, no, if we go to technology, that's still something that we've created, and it's actually exacerbating the problem by taking the human out of it.
Yeah. And that also the error is informative, right? But then after a while, if the same thing is being reproduced, right? Like if hegemonic hierarchical logics are being reproduced, that's not error, right? That's intentional. And so at what point do we say, okay, we need to shift? That point is now. So that, yeah.
Yeah. So there's a related question, and I think, Nicole, this gets at what you were just saying. So someone from the audience asks, how can we also acknowledge the insecurities and fears of the researchers that might worry about stepping off this new ledge, many of whom might not have the kind of training that we're talking about, or the kind of training that someone might need to do some of these things? And so, Nicole, you were kind of getting this a little bit with saying like, some people are ready to like do this work. I wonder if you want to say more about that.
I want to say more because we're all fearful. We're all insecure about it. It's all vulnerability. Like no one has ownership over that. Like it is hard for me to say what I'm saying in this space. That's not easy to do, right? When you are speaking truth to power, that's not easy to do. So yeah, like to me, that question is like, we all are dealing with that. Right. And I'll just say that we're all dealing with that.
And what if we saw, wow, I was just thinking about this. And what if we looked at vulnerability as a gift that you bring to different spaces, a gift that enriches spaces, that builds community? What would it look like if we brought vulnerability to spaces to try to build community, to build understanding, to build trust? And when bringing vulnerability to a space, you also were accountable for what you brought. You also were accountable about the things that you were speaking and the ways in which you were engaging, but being humble to listen to the ways in which you are shaping the space, being vulnerable to getting this feedback. Vulnerability is a gift, can be seen as a gift and not as this pathological kind of giving that disrupts the spirit of promoting one's health and promoting community and promoting well-being, you know? I don't know, I was just thinking.
Yeah. And I started with, I said I would begin with lived experience and return to it. That's my way of being. That is my way of being in community. That's my community's way of being with me. And so I said, I'll start with lived experience and return to it. And so that will be my last word on that.
Yeah, it also strikes me that if the biggest like risk you're facing is insecurity and fear, like it seems like that's already a form of privilege, right? And so I think, Alana, like you said, like being willing to be vulnerable, like give up some power, be okay with like stepping into spaces where it's scary and you feel insecure, and recognize that you're doing that because for other people, there are much more tangible risks than fear and insecurity. Not to say that those mental risks aren't tangible, but people are dealing with different things. So I think those are all of the audience questions that I have so far. We have about 5 more minutes. So if someone else wants to jump in and ask a question, that would be fantastic. Otherwise, I might ask Alana and Nicole if they want to think about final words to kind of wrap up the panel this evening, or just anything that they want to share. I'm thinking too. And Stephen's got his hand up. Yeah.
Yeah. Apparently, I do not have one of those little blue hands as a host. So, So I would I would like to invite you to say a little bit about like rebuilding trust and like after violations of trust, especially in a context where there are so many opportunities to sort of like lose trust once you have it, right? Because of, not recognizing the particular things that you're doing, being inattentive, even when trying to, work within a community to build trust. There's plenty of pitfalls along the way. And this is true of sort of like any relationship. And so if we're thinking about, research or healthcare as, trying to build these relationships. And I'm curious if any of you would like to speak to questions about, I don't know if it's exactly about how to build rebuild trust, but some of the things to be thinking about in these ongoing relationships related to loss of trust and then trying to get it back.
I'll give an experience that I had years ago when I was teaching at a community college with practical nurses who were all of, more of a lower SES, did not want to be there, had to be in my class because they had to do that for certification. And they were just very angry at me. And it was horrible. I mean, I wasn't teaching them a thing, I could tell. And after a couple of weeks, and probably it shouldn't have taken me that long, but I finally, just really poured my heart out to them that I knew I was a failure. I didn't know what to do. I was trying, but I really didn't know what to do. What would they want me to do? And, how could we make this better? And I didn't even think I intentionally did that, but I didn't know what else to do. But anyhow, my point was, they gathered, they discussed, the course just blossomed based on what they wanted, what they needed to do. And it was, as I think Alana was talking about, the kind of cultural humility, the emotion that they saw, which typically, you don't think is professional, the admitting that you, at that point, which was totally honest, I didn't know what I was doing, admitting that, I don't know, that it ended up to be a success unintentionally, but.
And Celia, it also feels like in your example, by being vulnerable, you also are absolutely sharing the power, you know, and how does the sharing of power not create, you know, create a more equitable space, a space where folks feel empowered, they feel agentic, they feel as if they have opportunity to speak their truths. You know, it helped to create equity in a space where there are traditional hierarchies, you know, so yeah.
So I would like to chime in with my last word and just say that to me, trust comes with accountability. And until that accountability happens, there will be no trust. But the work still continues of building with community and being in community and building and creating and maintaining spaces that do serve us. So that work will still happen. But for me, in terms of the context of that conversation and where we started, trust won't be there until the accountability is. But, you know, the moment that we're in now, I can't wait for that to happen. So definitely shifting into a new way of being.
Yeah, and I'll just echo what you all just said. I think, Alana, I think you're the one who at the beginning of this used the language of perfectionism. And I think that part of being accountable and part of avoiding perfectionism is admitting when you did something wrong, right? And I think that that's the first step, is like owning your mistakes, and that does make you vulnerable. But I think that that's part of being trustworthy, because if someone doesn't admit when they made mistakes, you don't know if they're just going to pretend that they didn't do anything and just keep going on. So, yeah, I feel like that kind of vulnerability is important too.
It is, but I just want to say, like, there have been times where people have made a mistake and they have harmed me, and I cannot wait for them to realize their mistake and apologize for that harm, because that keeps me locked into a relation to them where they're taking some of my power. And so for what I was talking about before was that, yes, it would be great, you know, for structurally and the systemic harm that's ongoing, that there's a recognition of that. But knowing that these systems are designed in this way, I can't wait for that. And so I think that's just the collective sense, and how do we shift into new ways of being.
Mm-hmm. Could I ask you, I know we're running out of time, but could you say just a little bit more about that? So what I hear you saying is that part of this structure of making mistakes and apologizing is like preserving this power imbalance, which is part of what we've been talking about.
Yeah, like systemically, it's not a mistake, right? Like, it's not a mistake that these structures are designed on exploitation. Like, that is not a mistake. And so if someone is acknowledging, and if people are engaging in actions where you've just got to come to the realization that that's not a mistake, that it really does shift the lens of how you move forward in doing the work. And it's not to say that what Alana is talking about, there's relationality there too about doing that vulnerable work, but that also comes with trust. And I will do that work in particular communities. So to me, it's about being clear on that, because I cannot continue to put faith in, trust in institutions that have shown that they are not trustworthy. It's harmful to me and my communities.
If I might say something, I'm Renal. It should be listed as Rev. So I got here kind of late, but along with that, I do believe that pride actually gets in the way of what we are when we're trying to rebuild trust. It has a lot to do with, as you state, the institution and the entire process being institutionalized. So, I mean, with that, with developing community relationships, with trying to regain trust, how do we start that if we have so many institutions that are based on pride and based on past institutionalized policies?
I like what Nicole was saying about it's not a mistake. I think it's very important. I think it has to be probably fleshed out for all of us across time. But But the fact that systemic racism is purposeful because it empowers others. It preserves a system in which others have and others don't. And so I'm really struck by that statement, Nicole, and it's something very important to think about, because I think a lot of this diversity training is, kind of almost didactic. It's kind of focused on facts, and if you know the facts, then everything will be fine because it's just you, as opposed to you're working in a system that you're actually benefiting from, and that system is not a mistake. It was intentionally set up for the harms that it's doing to some people. So I was very touched by that.
Yeah, it makes me, there was just a narrative published in the Lancet this past week by Kimberly Manning called More Than Medical Mistrust. But she says, we talk a lot about mistrust, but mistrust is just the tip of the iceberg. What we're really talking about is racist institutions. And when we kind of locate just the mistrust as the problem, that's forgetting, like she says, it's just the tip of the iceberg. There's this whole thing that we're not talking about. Yeah. All right, so I think we're just about out of time. Stephen's nodding. So Alana or Nicole, if either of you want to give a final word, but thank you. Thank you both for being here. This has been a fantastic conversation. And I'm glad we got so many people involved.
Thank you for the invite. Yeah, to be a part of this conversation and dialogue. Yeah, thank you.
Thanks everyone for the conversation.
So thank you, everybody. And this will wrap up our conversation. If you needed access to the recording, please do let me know. You can email me. I will drop my email in the chat box now. But otherwise, have a great one.